Manish, when you go to your hospital and you have a new patient with locally advanced disease, who helps you and who works together as a team to treat these patients, form a plan?
Right, so that's a great point. I mean, I think that it does take a team approach. I mean, you know, we need the surgeon, the radiation oncologist, the pathologist, the radiologist to help us with understanding the stage of the tumor, the other intricacies of sort of where it is, what type of cancer it is, and you know, for patients with metastatic disease, you could argue that perhaps it's not so important, but I think actually it is, because to Ian's point, you know, even with a patient who has an endoscopy and the tumor is sort of in the proximal area, if there's a risk of obstruction, or you know, whether a stent is an important aspect or not, these are things that can be done that require a team approach. And I think, you know, if we're able to sort of really work together, we'll be able to give our patients sort of the best outcomes.
Yeah, absolutely. And in Japan, is that the same as well, that you have a multidisciplinary team?
Yes, we also take team approach. In our institution, we have two teams, esophageal cancer team and a gastric cancer team, because the location of tumor is very important. So if esophageal invasion or esophageal cancer, this patient was treated with thoracic surgeon. In contrast, the usual type of gastric cancer was treated with gastric surgeon. So we have two different teams. And importantly, at this time, adenocarcinoma in esophagus is not so common in Japan. More common is the squamous type. And also, we do not commonly use radiotherapy for adenocarcinoma in stomach or esophagus. So in this team, radiologists usually belong to the esophageal team, but not in gastric cancer team. Yeah. But anyway, multidisciplinary approach is very important.
Yeah, I mean, what you're hearing here, these are very complicated GI cancers. This isn't something like a laparoscopic colon resection. I mean, this is really a team approach, and not only with radiation oncologists and with medical oncologists and surgeons and even nutritionists and social workers and exercise physiologists, because these patients are also very sick. We make them very sick with treatment too before they get better, and so important. And with staging, how do you stage in Japan?
Yes, usually patient gastric cancer is detected by endoscopy and do a biopsy, as mentioned by Ian. It is very important to evaluate the histology. At the same time, we do a CT scan to evaluate the deepness of primary tumor as well as the lymph node metastasis. We not commonly use PET scan. We only use for patient with suspected distant metastasis, but not definitive one. And at the same time, we also do a laparoscopy for peritoneal metastasis, but it is also not routinely done for all patients. We only do it for a patient with a large primary tumor, as well as a patient with a suspicious peritoneal metastasis, such as the squamous type gastric cancer.
Yeah, very good point for sort of the more aggressive ones to check before you do the surgery. You know, Manish, we're in America, you're in New York, money central. You know, we like spending in our healthcare profession. Right. You know, what do you think about PET scans, endoscopic ultrasounds?
I would like to make a contrast with regard to the Japanese patients. So in the West, most patients actually present with locally advanced disease. And I think that's where we really do think that laparoscopy for staging for tumors where a CAT scan doesn't show metastatic disease is important. And that's one key issue. You know, the endoscopic ultrasound is important if we're making a treatment decision based on that. If, you know, we do think that based on, you know, part of Ian's work from the MRC, perioperative therapy with chemotherapy is important for locally advanced disease. And sometimes you can't tell on a CAT scan if it is locally advanced. So an endoscopic ultrasound is useful for that. In PET, with regard to PET scans, it does identify occult disease in about 10% of patients, and that data is consistent with other malignancies as well. It is of course standard for esophageal cancer to do PET scanning for occult metastatic disease, and in gastric cancer, it is done, but I agree with you, it's not done routinely.
Yeah, I mean, certainly we do PET scan as well as a routine, although the reason is more, we think that, a PET scan is actually a cost-saving measure compared to a radical operation or unsuccessful or open and close operation. So actually our surgeon view that is that if you've got a PET scan and actually end up showing metastasis, then you actually save the patient, most importantly, an operation. We also routinely would do laparoscopy before we start any neoadjuvant therapy. One interesting thing, I don't know how the Japanese do, is whether they send cytology or lavage and cytology during laparoscopy, and what do they do with the results? Because our surgeons certainly have a very mixed view about it, and some said they would, but others argue that if you can't see any macroscopic peritoneal disease, what is the information that is given by the cytology?
It is a very complicated or controversial issue. Even in Japan, we also have only cytology positive without peritoneal metastasis. Treatment for this patient is very controversial. If patient has some symptom, especially from primary tumor, usually gastrectomy followed by chemotherapy is a choice for treatment. But recently, activity of chemotherapy was improved, so more and more treatment is shift for neoadjuvant treatment strategy, dual chemotherapy, and then secondary laparoscopic examination, and then proceed to the radical surgery.
I mean, it seems like what we're hearing in this conversation is the importance of making sure, especially when patients are locally advanced, they're not metastatic, but especially in the locally advanced setting, again, the multidisciplinary team approach, but also the potential for referral to a specialized center who can help make some of these decisions, work on some of the staging, and try to put a good treatment plan together for these patients, and especially with the surgeons to make sure that even when you have ones that, depending on how high or where it's located within the gastroesophageal milieu, you might have a different surgeon that's doing the operation, or sometimes a combination of the two.